Today I'm not going to give you the conventional didactic available as a download, and you can download them so that you would know all the tests. It's a little boring to give the same talk again, so this time I thought I'll give a very concept-based talk. I'm not sure that any of you should take your shoulder exemption too seriously, because it may not be practical for you to use all these tests in your exam. You may not get the kind of rotator tear cases and all that. But then you can always use this information that I give for your future. So that graph has been borrowed from Marcin's textbook of shoulder. And shoulder is one of the joints which is very specific on conditions, because as the patient walks in, you have pretty much an idea of what his age is. And most of the conditions in the shoulder are sharply demarcated by age. So if you know that, it's a little busy slide, very complicated, but what it's trying to tell you is that the young patients are typically traumatic anterior instability, the middle ones are impingement patients, the late ones are the rheumatoid, frozen shoulders, and then going down, you've got degenerative joint disease and full thickness cuff tears in the 60s and 70s. So when you see a patient who's 65 and 70, then you're not going to be worried about doing your tests of instability on that patient. Similarly, when you see a 19-year-old patient, obviously you're looking for signs of instability. You'd rather do those instability tests before. So that's pretty obvious. What is often not emphasized is the history. And I think that's why I took this opportunity to go into details about the history part, because extremely important, especially in the shoulder. If you are given a reasonable history, you can come to a good structured diagnosis even on history, and then you can confirm that on your examination. But without the history, your examination is going to be all at sea, really speaking. So conditions in the shoulder are pretty much very specific, and you can boil down to a very perfect diagnosis 80% of the cases most of the time. So when you have a patient of the rotator cuff, I thought, what is the kind of history that you expect? So you're typically looking at an elder person, somebody who's perhaps gone into overhead sports and gym. The onset typically is very chronic. In an elderly person, he's had pain for several months, and then he's come down with a sudden onset, loss of movement and ability to lift. But you could have a young athlete who's had a repeated injury, and then he can present acutely after a major injury, fall from about 10 feet height and such things. Patients who say very specifically that they cannot sleep in the lateral position, on the left or the right side, you can clearly on history demarcate them as AC joint arthritis patients straight away. So it doesn't take too much of rocket science to diagnose AC joint arthritis on them. Athletes who have a weak throw, who say that they've been playing for years but now they cannot throw from the boundary back to the wicket, is suggested that he might have a slap tear. Okay. Just on that history, that's probably the only positive history that athlete would be offering. The pain again is going to be mostly at the deltoid area, palm spine, or the GT area, and they would say that this is the area of pain all the time. You must have typically heard of a patient that fell in the bathroom and then the symptoms started. Now that history is very important. A young patient who's had a fall from a running train or something and then started having shoulder pain. So all the shoulder symptoms started from the fall, which means that that fall was responsible for the onset of symptoms, so you could think of a slap tear later. So if you don't have a fall, then it will be criminal to make a diagnosis of a slap tear later. Remember this very important. Most of the times is missed by many people, that instability is a problem with the young people. But if you have somebody who's 45 and 50 and he's dislocating his shoulder, the incidence of rotator cuff tears associated with that dislocation is incredibly high. Unfortunately, it's a very uncharacteristic mix, because when the patient comes in with instability, he has pain and he's not cooperating with your tests and range of movements, and it's difficult to diagnose the cuff tear. But if you knew that he was 45 and he dislocated, then it should be running in the back of your mind that this is a candidate who should have had a rotator cuff tear. Patients with instability or slap tears, the only symptom they might complain of might be locking. And you would think, oh, there's nothing there, there's no pain, there's no stiffness, but locking should be taken pretty seriously. In an athlete, it's more of repetitive microtrauma. You know, when Gautam Gambhir gets injured on the field, it's not because he's had an injury during that time. It was waiting to happen. Because of the repeated wear and tear, his hamstrings were probably weak, and it's that one little blow led to that injury. So in an athlete, we're talking about repeated microtrauma, especially in a bowler who undergoes slap tears and rotator cuff tears and such things. And the only symptom sometimes the athlete will complain is feeling of insecurity, locking, or inability to throw. They look on the face of it as very minor, insignificant symptoms, but they are not. That is the only thing they'll complain of. They'll never complain of pain, they'll never complain of stiffness, etc. In a dislocation patient, now that's the patient you're likely to get in your exam. What is the kind of history you want to elicit from that patient? Typically, you find out what is the cause of the index dislocation. The first dislocation which happened, was it traumatic, was it atraumatic? So if it happened in the sleep, then it's more likely to be atraumatic, then you can be pretty sure that this fellow has probably got multidirectional instability. But if it's a high velocity trauma, such as a bike accident and such thing, then you know that he's got a big labrum tear, and this is a traumatic anterior instability, and then you can move on from there. Ask him how frequent it is. Typically they start once a year, once in 2 years, and then frequency increases several times over. Find out whether the patients could self-reduce their dislocation. If they could self-reduce, it means that it's a small tear or it's a slab tear. Or it could also mean that they have multidirectional instability. When initially it was self-reducible, and now it is unreducible, excruciating pain, takes hours for it to go back, they have to come to the A&E and casualty to get it reduced, which probably means that now they have developed a large hill sacks, the hatchet lesion is locking into the front of the glenoid, and that's why he's unable to relocate it. So you're getting so much information from history itself that you can already start working on the extent of damage this fellow has done. Dislocation in sleep means either there's a gross labrum tear or typically a multidirectional instability patient. Do find out burners, stingers, patients of instability get dead arm, the complete numbness of the arm, especially in throwers or players. And then that lasts for a few minutes, they come off the play, and then it settles down and they can get back to play within 10 minutes time. So it's a very pertinent, very important history that you must understand. Posterior labrum tear patients and slab tear patients are unlikely to dislocate. So they are the patients who are likely to complain of only subluxations. So immediately you know what is likely to happen. Now the shoulder is very peculiar. The pain is rarely at the shoulder joint. Most conditions the pain will all over the place. So in the early stages the pain is at the primary side of the lesion. Okay. And then as the disease progresses they start getting impingement, and then they start getting neck pain and medial scapular pain and such things. Leg pain is typically depending on which muscle is compensating for the weakness. So you have a rotator cuff tear patient is going to have lower trapezius pain, neck pain, medial scapular pain, typically. If they start impinging anteriorly because of a spur, then they're going to get a lot of long enough biceps tendonitis as well. The lower limb examination is important for the athlete who has injuries such as a golf player and a tennis player, but not a conventional patient as such. So remember that, you could be asked on that, because the kinetic change or the force for a javelin thrower, 50% of the force is initiated from the lower limb. So if he has a weak glutes and weak tender Achilles, then he's not going to be able to throw the same distance. That's the justification for doing the lower limb examination. Always strip the patient waist upwards, start from behind and do a modular examination. Modular examination means that if you are doing a 60-year-old lady, you do a rotator cuff test first. You don't need to do tests of instability. Nobody is going to quarrel with you because you did not do the artificial test on a 60-year-old lady. Remember, in an athlete and the young patient, they could have rarely a rotator cuff tear, but that rotator cuff would be incredibly strong. You must then do comparisons with both sides. That's very important. Look at the tender spots. Each spot has a story to tell. Now, typically the coracoid, even in normal patients, is tender. So don't start probing on the coracoid and say that he has got coracoid impingement. That's ridiculous. Biceps tendonitis, you feel the tendon is right in the groove there. Greater tuberosity tendonitis greater tuberosity pain tenderness is suggestive of anterior impingement, acromial spur, and scapular dyskinesia. Palm sign is typically suggestive that the cuff is weak, so either you have a supraspinatus tendonitis or a rotator cuff tear. Classically, AC joint patients, as I said, will complain of not being able to sleep on a lateral position, and then you ask them, where is your pain? And that's a good thing to do. Ask the patient, point out your pain area. With the finger, they will point out here. Whenever they do that, finger sign, it's very classical of AC joint arthritis. Posterior pain could be because of a tight posterior capsule, typically limited internal rotation, or posterior pain can be also because of suprascapular nerve entrapment. Lower trapezius and medial scapular pain is typically compensatory traction and tendinopathy because of the weak rotator cuff pain. In terms of examination, when you look at the patient, assess for the laxity, look for the wasting. Now this is the national javelin player from Jalandhar, and you can immediately see that his scapula is not sitting well, and he has very obvious infraspinatus atrophy there. You can see the hollowing there. Okay? And sometimes they have hypertrophy of other compensatory. Typically athletes will have a trapezius hypertrophy because they're using too much of trapezius to compensate for the weak rotator cuff. So observation is very important. You all know about range of movement, how to assess them and which movements to assess. Just make sure that internal rotation is rarely assessed at degrees because internal rotation typically tends to go behind. So we examine it as side, buttocks, SI joint, L5, L1 and such things. What is important I would like to tell you is to read between the lines. So the nuances of range of movement. If you have a passive range which is more than active range, then you are typically thinking of a rotator cuff tear, obviously. When you have an impingement, then they typically have a painful arc from 50 to 120 degrees. That range can be variable. It could be 40 degrees to 100 degrees. So it's very individual, but between 50 to 120, when they're catching, they get pain and then they get relief, is typical of classic of painful arc syndrome. Often patients now, you need to discern between different range of movements. Now often patients have a good forward flexion, they have a good abduction, but their rotations are restricted. Okay, whenever that happens, you must start thinking what is happening here. It just means that that ball and socket joint is behaving like a hinge joint. And that's why you're getting unidirectional movement, the rotations are grossly affected. Now when does that happen? So immediately if you start deducting, you can analyze that when you have an adhesive capsulitis, when you have an adhesive capsulitis, then the rotations are grossly restricted. Whereas forward flexion and abduction are reasonably okay. If you have osteoarthritis, again the joint behaves like a hinge joint, does not behave like its original ball and socket joint. And a dislocation, especially a neglected posterior dislocation, will behave in this manner. Then they will have a very impressive forward flexion and abduction, don't get deceived, but if you've got blocked rotations, so they've got blocked and introduction, no external, it becomes posterior dislocation, other way around becomes anterior dislocation. So be very careful, the range of movements need not be. Just don't put down the range of movements mechanically. Try and read the story behind that. Now remember, you are do all those Hawkins tests and anterior tenderness, GT tenderness, and you make this impingement, patient has impingement. Don't make impingement as a diagnosis. In shoulder joint, whenever the biomechanics go crazy, the first thing that happens is impingement, because anything that changes the biomechanics of the shoulder will lead to impingement. What you need to find out is what is the cause of that impingement. So whether it's a rotator cuff tendonitis or whether it's a calcific tendinopathy, whether it's an acromial spur and such things. Instability is multifactorial. Okay, there are many things happening there. So just don't look for lateral tear. Look for the associated weakness, laxity, and the position of scapula at the same time. Many shades of grey. Don't call it recurrent dislocation. It should be mentioned as recurrent instability, anterior or posterior of the shoulder. Okay. So typically, there's some gross important signs that you ought to know about is the crank and Job's test. That's the Job's relocation moment. You take your hand off, patient winces in pain. That's typical of anterior instability. It's similar to the load and shift test. This is Sunil Krishna doing the load and shift test, which is similar to the crank and Job's test. You could use either of those. Even one of those is enough. You don't have to do all the shoulder tests because it gets complicated from there onwards. It is best to do this test supine. It's very embarrassing for a student to get that patient to dislocate right in front of the examiner. That will be very embarrassing. So do that. Sorry, missed that. Posterior instability, there are no good tests for posterior instability, but this is Yankees test and sometimes patients are able to do that test on their own. And what we typically do is on the, you can see that head of the humerus jumping on the glenoid tail. So that's the test for posterior instability. Very difficult to do, very uncommon, unlikely that you'll get it. But typically players of tenicoid or superphysical, they are the ones who put their shoulders into risk for posterior labral injuries. That's, you need to test the range of movements in an athlete in 90 degrees external rotation, 90 degrees internal rotation. And then you get the ratio. In a normal person, you should have a 1:1 ratio. So in a person who's a slap tear and athlete, they're usually having hyper external rotation with loss of internal rotation. That is called GIRD, which is glenohumeral internal rotation deficit. Again, slap tear is unlikely to come into your exam, so you need not be worried about it, but maybe you would start getting a note on that on your theory exam, because theory papers you're getting all these advanced, 20% of the questions are typically recent advances, so you better know what the slap tear is about. But there's no specific test. The one test that we rely on is the O'Brien, and that's the reasonable test, which is decent specificity and sensitivity. And you could also do the Grant test, which will lead to posterior pain. But you must understand, if the superior labrum gets damaged in the dynamic mode, so patients who are getting pain in that throwing movement, or typically when traveling in a bus and their hand gets jerked, that's when they get pain. So it need not be an athlete who has the same type of pain. Biceps tendonitis is also secondary. The tests are there on the website, you can download them, but this is the speeds test, and that's the most reliable one that we use, and I think that's more reliable to do the forward flexion against resistance. But at the end of any of these tests, you must ask the patient, where is the pain? And the patient must point out towards the longer biceps in a straight line. And you look that the examiner's finger is there on the biceps tendon all the time when he's doing the test. That is very important. Then the examiner knows that you understand the concept of the test. That Dr. Jones sir was telling you, that you do not know the test itself, you must understand the concept behind the test. The reason I call it the neighborhood syndrome is that you must be awake and alert. If you get a patient of biceps tendon subluxation, don't get excited that you got a diagnosis. The key thing is that that shoulder or the patient is trying to tell you is the biceps are dislocated because it's lying in the neighborhood. The insertion of the subscap and the anterior rotator cuff is right next to the longinal bicep. So if you have an anterior cuff tear that involves the pulley of the longinal biceps, it's going to dislocate. If you have a subscap insertional tear, then your longinal bicep is going to dislocate. So that moment you see a bicep dislocation, the next test you must do is a subscap test. That should follow in immediate. That means that you understand the concept behind a bicep tendon dislocation. And that's why the anatomy is very important. We talked about AC joint problems. You can get patients with osteolysis, AC joint arthritis. AC joint instability is probably likely to be commonly kept in your exam, and you must know what are the treatment methodologies. It probably covers a short case for you. But AC joint arthritis, typically patients have associated rotator cuff problems. They usually have a cross reduction test positive, and they have only restriction of terminal internal rotation, terminal flexion. They don't have gross stiffness. The AC joint gets involved in the biomechanics only in the terminal ranges as such. In terms of the rotator cuff, you all know about the supraspinal test. IG described them, so you must have some reference value for that. This is the empty can test, that is a full can test. You need to do both. If both are weak, then it's more likely to be a full thickness cuff tear. But if only the empty can is weak and the full can is strong, then you can safely disregard that and probably label it as either a rotator cuff tendinosis or a partial cuff tear. So then it does not have the same importance as a full thickness cuff tear. Infraspinatus, again, a lot of volleyball and basketball players have isolated infraspinatus weakness, and you must know how to test them. If you have an isolated infraspinatus weakness not involving supraspinatus, you must think of neuropathy, especially in the younger patient, because your cuff tear patients are typically going to be 60 years and above as such. And that's a test for external rotation. Remember, the examiner's other hand is on the infraspinatus. That tells the examiner immediately that you are understanding, you know what has to be done, you know which muscles to be recruited, and you understand your anatomy. This is a much better test. This is the same national javelin thrower, and you can see incredible isolated infraspinatus weakness against gravity. So that is a Horn-Blower's test. It's more specific for infraspinatus because the first test, the external rotation, could be positive, could be negative because the teres minor is intact, and teres minor can contribute to external rotation. But again, you must know your anatomy on that. So this is Christian Gerber, and Christian Gerber gave us this test, and that is called as the Gerber's lift-off for the subscapularis, where the patient tries to throw the hand of the examiner back behind, and that's part of internal rotation, and that's called when subscapularis is present, which is associated with the longinal biceps tendonitis. And you could do the same test as internal rotation in that position as well. There's a lag sign. I think this may not be necessary for exam, but those who are going for board would want to know that whenever there's an isolated infraspinatus tear, then the balance of the external rotation, internal rotation is lost. And so the subscap, being the stronger muscle, pulls the arm in neutral position into internal rotation. And that's why you can see on this side he's able to hold it in neutral, but on this side the whole arm just falls forward because the subscap is much more stronger than the infraspinatus is not there to restrain that. Okay? So this was first described by Hertel, and it's a very obvious sign. You don't even have to touch the patient. If he stands like that, immediately you know that the infraspinatus is deficient in there. So crepitus, don't miss that. There are several reasons for crepitus: bursitis, rotator cuff tear, and osteoarthritis are the three most common causes of crepitus. The bursitis crepitus is fairly superficial. The rotator cuff is a much deeper tendon crepitus, and osteoarthritis crepitus is like a grinding sound that the head of humerus makes on the glenoid. And clinically, you can diagnose osteoarthritis. You don't need to wait for the X-ray. Pec major tears, you'll see young athletes, wrestlers, bodybuilders come up with this tear, and you can see the retraction of the margin of the pec major on contraction. That's the test you want to do, clasping both the hands together in forced adduction. And you will see it is never gone completely. It's usually only the sternoclavicular head that tears up and retracts. If you get a young wrestler with a pec major tear, then you can rest assured that he has been on steroids before. So that is an additional information that you can give to your examiners for scoring a few more brownie points. Don't miss this. You always miss this because you don't ask the patient to take the shirt off. And patients with long thoracic nerve compression or serratus anterior weakness and weakening of the scapula will present with shoulder pain and neck pain. They will not come and tell you, "Here, I have a weakening of the scapula." So that look for them from behind, do the wall push test, never miss this. Isolated wasting in a young patient with of the infraspiratus cannot be anything else other than suprascapular nerve compression. Do remember that laxity is perfectly normal. You can have a painful shoulder in an athlete with one side lax and one side unstable. The definition of instability is painful laxity. Laxity per se is not pathologic. It's perfectly alright. So don't make a mistake in your exam because the examiner can make you go around in circles by saying that you've got instability on this side, he has instability on the other side also because C circus sign is positive. So you can say that that laxity is physiological because it is pain-free. So pain-free laxity is normal, painful laxity becomes instability as such. Athlete is different, we don't need to go into that because unlikely that you will get that in your exam. I'd just like to finish off that the examiner can ask you that how can you reinforce your diagnosis of impingement that this is not cervical spondylosis and this is shoulder problem. So in which case you can talk about the Neer's test. You must distinguish between the Neer's sign and the Neer's test. The Neer's sign is for impingement, the Neer's test is when you inject xylocaine or lignocaine into the shoulder joint. And then immediately, within 3 minutes, you should get a patient who's completely pain-free. He will tell you that the pain is gone completely. And that reinforces your diagnosis. So he's not going to make you do that in the exam, but you must use that as an adjunct to reinforce your diagnosis. But do be careful, not talking about steroid injections. There can be errors during diagnostic injections because if you have an AC joint arthritis patient and you do inject the AC joint, he can get pain relief even if he has impingement because some of that fluid can trickle into the subacromial dorsal because in arthritis the capsule is ruptured, damaged, and so the fluid can trickle in. So you must understand the nuances that every test has its fallacy. If you think on your feet, then you won't miss it. It is very important. Okay? So thank you for your attention, but you must understand that tests are never 100%, unlike some of the other sciences which cannot guarantee 100% relief. Thank you.
Non-registered manufacturers. This is not happening in the pharmacy. But in the medical devices, you are seeing this happening. And thereby, in 3.5 years, have we met regulation? The objective.
Fractures. It expands.